Welcome to our June seminar as part of the Prevention Research Center for Healthy Neighborhoods seminar series. In today's seminar, Dr. Nemeth will discuss findings and lessons learned from her research to optimize a smoking cessation intervention for homeless youth and to create and evaluate the C.A.R.E. model designed to increase domestic violence advocacy, organizations' capacity to better meet the complex and often interconnected health concerns of domestic violence survivors, including brain injury, mental health trauma, and substance use. Dr. Nemeth will also share insights learned from work supporting the Ohio Department of Health Office of Health Equity's response to COVID-19 across Ohio's diverse populations. Before we get started, just a few logistics and housekeeping for today's seminar. We recognize that in this format, you can't see who is on the call. If you could please use the chat feature to write down your name and organization to let others know who is here and joining the presentation, we'd appreciate that. For questions, we ask that you please use the Q&A feature. Also, there is a raise your hand feature, which you can use during the question and answer periods if you would like to request that your microphone be unmuted. Please connect with us through our website and social media to be up to date with any future events that we have in our center. And I'd like to welcome Dr. Nemeth today. Dr. Nemeth is an assistant professor in the OSU College of Public Health Division of Health Behavior and Health Promotion and a faculty affiliate of the OSU James Comprehensive Cancer Center and of the OSU Chronic Brain Injury Program. Dr. Nemeth holds a PhD in public health, an MA in women's studies, and a BA in world religion and ethics. Dr. Nemeth is an intervention scientist with expertise in gathering information necessary to make public health interventions accessible to priority populations and optimizing behavioral interventions to be delivered in community settings to reduce disparities. She is the principal investigator on an NIH-funded career development grant to optimize a smoking cessation intervention for homeless youth and of an OSU chronic brain injury grant to understand community health center needs in identifying and treating brain injury among domestic violence survivors. In addition, she has provided consultation to the Ohio Department of Health, Office of Health Equity regarding COVID-19 response in Ohio's communities of at-risk of disparities and is the co-leader of Ohio's COVID-19 populations needs assessment. Welcome, Dr. Nemeth, to our seminar today.
Thank you so much for having me here today. And I just wanted to, I'm at home and there's someone at the door, so I apologize. It's always an interesting experience when you do these presentations at home, what happens. So can you practice this beforehand, so let me make sure this is coming up. Okay, does that look okay?
We're still seeing where you can see your notes, your editing version of the slideshow.
Okay. How about now?
It hasn't changed screens to the presentation mode yet.
Okay, let me try one more time. Sorry about this. How about now?
Yes, now we're seeing the slideshow.
Okay, wonderful. All right, so thank you so much for having me here today. I greatly appreciate joining everyone at Case Western today, and I really do appreciate the invite to attend and actually many of the collaborations that are happening between The Ohio State University and Case Western Reserve and the Prevention Research Center for Healthy Neighborhoods. So I really appreciate this opportunity to share what I'm doing what we're doing in the Central Ohio area. And I think you're actually going to see maybe some ways that what we're doing and what you're doing connect. So thank you for having me today. I am going to speak about optimizing public health interventions for health and for health justice in particular in some of our most vulnerable populations in the state. And I've really come to define my work by this, recognizing structural injustices. I really see myself as a health equity intervention scientist who's dedicated to help survivors of interpersonal violence access safety, health, and social services and find success with cessation and other health risk behavior change, given the context in which they're trying to make that change. And that includes the historical and the structural context, oftentimes for the populations in which I'm working. And so I use methods, and I'll talk about those methods today, that really allow me to understand what that context is and how it is that we have to target interventions to make sure we meet the needs of the population, all populations. I just wanted to thank my research lab, Interventions for Health Justice, and all the amazing staff and students, from postdoc researchers through undergrads that spend time with me every week, really, and also key community partners who are involved with this work. All of my work is community-based action, participatory research, and I have community partners involved in all aspects of the research process. And I just wanted to acknowledge that I have funding from lots of different sources that supports the work that I'm going to talk about today. So in my research, I primarily work for health justice with both homeless youth and domestic violence survivors. And I really work with the agencies that serve them. In a lot of ways, I work through agencies where these populations are coming for other kinds of services, for safety services and other kinds of social services. And I really work with the agencies and the populations to figure out how we can bring public health protections and behavioral interventions into community settings. Both of these populations actually have a lot in common. So I know I've separated them out here, but homeless youth actually experience a lot of violence in the home, oftentimes before homelessness. And they also experience a lot of interpersonal violence once homeless. And so they're both populations that have experienced a lot of interpersonal violence and a lot of trauma. And I'm going to tell you about why it is that I work with these populations in just a second. So I really focus on service access, especially to public health protections and health behavior change, in particular to combustible tobacco smoking cessation to improve population health. And this is because in the populations I work, combustible tobacco is still, they're still smoking combustible tobacco at a very high rate, 70% or higher. And combustible tobacco is still the leading preventable cause of disease and death, premature disease and death. And so it is the behavior that I've really focused my efforts on. So how did I get here? I was actually born a Buckeye in OSU Hospital over 40 years ago at this point. I spent the first part of my professional life actually working as an advocate for survivors of sexual assault and domestic violence in community settings, primarily in the Central Ohio area. I started in court-based advocacy and a domestic violence and stalking unit before I went back to receive my master's in women's studies at Ohio State. And then after that, I spent time working at the Sexual Assault Response Network of Central Ohio and an education position before moving up to Helpline of Delaware and Morrow counties, where I spent over 5 years as a director overseeing all of their prevention services, which included sexual and domestic violence prevention, as well as mental health promotion and suicide prevention in community settings. And I also oversaw the sexual assault response program through Helpline there. And so Delaware, Morrow County is a very kind of diverse community. Delaware is actually one of the healthiest counties in the state. Morrow County is actually a rural county northeast of Delaware. Very different cultures in the two counties, and so it was a wonderful actually opportunity to serve kind of a diverse populations within the state of Ohio. But it was really through that work that I got to work across community partnerships in a lot of different ways. I led a suicide prevention coalition in both counties for over 5 years. We led sexual assault response teams in both counties for over 5 years. We worked in partnerships with hospitals, criminal and civil courts, health departments, prevention providers, drug and alcohol treatment, mental health counselors, school districts, faith-based institutions and colleges. So a lot of on-the-ground community-based coalition development work during this time. I also volunteered my time to found a statewide coalition, the Ohio Alliance on Sexual Violence. At the time I was doing community-based work, our local domestic violence or sexual assault coalition collapsed. And really I spent 6 years of my life helping to found the new organization. This also really helped me develop partnerships. And I ended up across the state with sexual assault programs that are serving survivors, but also with state government and with federal government, because the coalition actually had to be identified by the CDC as Ohio's coalition to address sexual violence. So the Federal Office on Violence Against Women would release federal dollars that were allocated to our state for sexual assault prevention and response work. And without a coalition in place, that money was not coming to our state. So it was a critically important process to put in place a coalition, but bringing very diverse people together to do it. So why did I return to earn the PhD? I really did feel we were missing something for so many survivors of interpersonal violence. And so interpersonal violence is really violence between individuals. Domestic violence can include child maltreatment, intimate partner violence, and elder abuse. And community violence includes assault by acquaintances and strangers, assault by traffickers, and violence in the workplace and other institutions. And interpersonal violence really includes a range of violence, including physical, sexual, psychological, as well as deprivation and neglect. And you may or may not know that populations who experience structural inequities are more likely to be targeted for interpersonal violence. So racial and gender minorities, sexual and gender minorities, those who are at social disadvantages for those living in poverty, those actually living in rural underserved regions in our state. So a variety of populations are experiencing interpersonal violence, domestic violence, sexual abuse at higher rates. And this is really impacting long-term health outcomes for these populations. And I really do believe that through interpersonal violence is about establishing and maintaining that structural imbalance. It reinforces the structural inequities at the interpersonal level. And so my focus really has always been on interpersonal violence and survivors of interpersonal violence. So in the US in particular, 1 in 3 women in her lifetime will experience sexual and domestic violence. It's a public health crisis. And as I was saying, this is targeted at higher rates in certain communities. So for instance, multiracial men and women are at higher risk for intimate partner violence, and bisexual and lesbian women are at highest risk for rape, physical violence, and/or stalking by an intimate partner. And women with sexual and/or intimate partner gender-based violence exposure experience have disparate health outcomes. They have worse health outcomes across a wide spectrum of health outcomes. They use healthcare at higher rates and have higher healthcare costs. And they also engage in a lot of high-risk behaviors, and oftentimes are not able to engage in service. They fail service. Oftentimes the services they're seeking, they're not able to engage fully and benefit from. So for instance, when I worked at Helpline, it was not uncommon for survivors that we worked with to access community mental health or drug treatment services, and really to come back to us to say, this is just not working. Almost smoking combustible tobacco was like, it's like everyone was doing it. So when our rape crisis center went to we went to a smoke free policy, a tobacco free policy on our grounds. There was a lot of discussion about what that meant, because the amount of survivors that were taking a smoke break was a lot. So we definitely saw a lot of the populations who were engaging in our service engage in high-risk behaviors that were also leading detrimental health outcomes, including higher rates of suicide, so losing survivors to suicide. And I can tell you that in many ways, it's those survivors that we lost that really motivated me to come back to school, to figure out how it is that we could target our behavioral interventions to these populations differently. And so I think it's also really important to note, while I was working at Helpline, I also oversaw a teen advisory board. And at that time, the public health department was leading a teen advisory board, and they were focused on tobacco and tobacco prevention. And we had a teen advisory board that was focused on suicide prevention and mental health promotion and violence prevention. And we brought our two boards together at some point to really focus on primary prevention in the community. And the public health department was like, well, all your youth have to sign this statement saying that they're going to be tobacco free. And I looked at who was on our board, and I was like, well, that might be an issue. As I was working with, survivors, many of whom had been molested as youth, many of whom were already using tobacco. And so it was, I think despite public health's focus on these universal primary prevention efforts, both with violence prevention and tobacco and other drug prevention, I definitely was working with lots of youth with exposures to both, and interacting with lots of public health messages that weren't resonating with the populations that I was working with. And so really recognizing that universal primary prevention works for a lot of people, but that we needed a targeted intervention for our highest risk population. So it's really with this history, I returned to pursue a PhD in public health at Ohio State, in health behavior and health promotion, and really understanding and realizing we were missing something in terms of our interventions in community settings. And so I really am an advocate turned scientist seeking health justice for survivors with an interest in transforming communities and the systems that serve communities, so health justice is attainable for all, and especially for those who experience interpersonal violence. One of the things that really stood out to me when I was working on my PhD, and this is it. Actually, it's these articles by Kenneth Warner that really turned me towards intervention and cessation rather than regulation. Ohio State has a phenomenal group of scientists working in tobacco control and regulation, and a much smaller group of scientists working in cessation intervention. And so, as I said, I focus on tobacco cessation because it is, the leading cause of preventable disease in the populations that I work with, and it's so pervasive. not to say that there aren't other modifiable risk behaviors that need to be focused on in these populations, but they actually really want to stop smoking. But it was these articles that Kenneth Warner authored that really spoke to me. And you know, as overall smoking prevalence has decreased in the US, and I think everyone here knows that, smoking disparity between socially privileged and disadvantaged populations has really increased. And this increase is not due to differential rates of smoking uptake necessarily, but due to differential rates of smoking cessation. So cessation interventions, our evidence-based cessation interventions, are either not accessible or not working for our disadvantaged populations or populations that are experiencing health disparities. And so for me, this really sat with me, and it was sort of, I just remember reading these articles and thinking to myself, okay, I'm going to commit myself to intervention and cessation. And so, you know, I truly believe I have the skills and the depth of knowledge working with the vulnerable populations really to help target evidence-based behavioral interventions to populations experiencing interventions, and really do believe that not all populations have the same access to or equally benefit from evidence-based interventions. We really have to, you know, when we apply universal primary prevention across the population, we can create disparities, and so we really need to think through things differently and target interventions. And I also think we, you know, I spent a lot of time thinking about how it is that we're building interventions and the processes we're using to develop what are evidence-based interventions, and how these processes, by the time we have an evidence-based intervention and then are trying to move it into community settings and it's failing, it's not working, you know, I feel that that's because we haven't worked with populations. We're taking the very populations that we need to be engaged with right from the beginning out of our trials to begin with, and instead of engaging them from the very beginning. And so I was really looking for a new framework and new processes that would allow for me to target behavioral interventions to address the reasons why certain populations have not been able to reap the benefits of evidence-based interventions. And so if you think of the foundational boxes here as evidence-based intervention, and here I'm kind of depicting cessation. So if you have a group of smokers and you just offer, you know, what's considered evidence-based at this point, counseling and NRT or some sort of drug to help with the cessation intervention process, and we just kind of offer it out. Some people, and oftentimes the most privileged populations, have been able to access that intervention and quit smoking. But the populations I'm working with, those that have experienced violence, that are represented by the purple ribbons here, and those that have brain injuries oftentimes have not been able to access these interventions. So the critical question that I'm really interested in is what components of intervention need to be targeted so interventions and public health protections are accessible to all. And so this is the approach that I use. And this is sort of the approach that I've landed on and that I'm going to talk about today. I use a approach of optimization. So trying to find the process of finding the best possible solution subject to the given constraints. And Linda Collins actually brought this, it's called the multi-phase optimization strategy, from engineering really into public health and health intervention development. And it's a very systematic way of looking at the way we develop interventions, and I'll talk about it here in a moment. I combine this process of optimization with an evidence-based method that was actually developed through the UK government to develop public health interventions. So I combine these two things, and I'll talk about that here in a second, but really what I do is I investigate behavior in context to identify modifiable targets of intervention for the populations that I'm working with. And oftentimes these are new targets of intervention, different than what's part of the evidence-based intervention that's already packaged and out there. And then understanding, and given the constraints of the context in which I'm trying to help make behavior change or trying to move public protections into the community, then I optimize to meet the needs of the community. I've done a lot of this step one work, not a lot of the step two work yet. I'm kind of young in my career. So I'm going to talk today primarily about my work in step one here, but I'll give you a little taste of where I'd like to go with step two. I really do believe from kind of the health justice and social justice framework that the constraints that we really have to consider include history, structural trauma and its legacy, and the context that leaves the populations that we're working with, in as they're engaging in behavior and as they're trying to change behavior. And so I needed a process that would allow me to do that. So let me talk about optimization for a second. So if you're not familiar with optimization, the multi-phase optimization strategy actually has these 3 phases, and I'll go through each phase so you can have an understanding of what's going on. In the preparation phase, you really lay the groundwork for optimization. It's here that we derive and revise conceptual models and identify a set of candidate components that you want to include in your intervention. If you think about interventions, any sort of intervention, oftentimes our interventions in health are multi-component interventions. So we bundle maybe together counseling and medicine, for instance, or maybe there's some sort of a counseling component, and then we have some sort of an environmental component that we're laying on top of something that we're doing in a community setting to try to change behavior. And so we have multi-component interventions, and oftentimes what we do is we just bundle everything together and we test that bundled intervention against a standard of care in a randomized controlled trial to see if it's better, right, than our standard of care. And what optimization does is it allows us to stop, and it actually allows us to look at our intervention components. And here with preparation, it allows us to identify new components of intervention, okay? So it demands that we use theory and that we have a conceptual model for how it is that we're moving forward with the identification of our candidate components for our intervention. We identify those then based on our model, and we pilot test to see if it's feasible to implement those things, and we identify optimization criteria. So optimization, I'll talk about that just in a second here, but the optimization is actually moving through this process to identify the set of components that we're actually going to end up bundling for evaluation. So in preparation, we're naming all the possible components that we could possibly put in our intervention. But in optimization, we're actually trying to figure out, okay, based on our optimization criteria, what components are we actually going to bundle, given the context, given what we need to do with this intervention in order to move forward with it. And there's a lot of different ways to run optimization trials. You can run things like factorial experiments where you randomize people to each component of the intervention. So as people are coming into the intervention, you turn different components of the intervention on or off. There are ways to do adaptive intervention trials. So there's lots of different ways to do optimization. So there's not just one way you can do optimization, and actually you can run a lot of different optimization trials in this stage before you figure out what kind of intervention components you want to bundle. And this is directly from the Methodology Center and Linda Collins, actually. So the goal really with optimized interventions is to assemble the best intervention possible. Well, it can be here with no inactive components. So if you think about working with homeless youth, for instance, we can throw the kitchen sink at them, but maybe we don't need to throw the kitchen sink at them. Maybe if we just give them, one or two things that's really going to help them stop smoking, and we're going to have a better impact on their ability to stop smoking than if we tried to engage them in all sorts of things because of the nature of what they're going to. We can also, though, optimize on other things. So say we can only spend $200 for each participant moving through an intervention. So we can figure out what intervention components have the best outcome given the cost that we can spend. Or maybe our staff time can only spend less than 10 minutes on delivering an intervention. So what are the intervention components that we can deliver to get the best result for that intervention, given the fact that our staff time is less than 10 minutes? Or our participants can only spend 2 hours engaged with the intervention itself. And so you can optimize on a lot of different things in this phase that allows us to consider the context in which we're delivering the intervention. And really the researchers determine which optimization criterion to use. And I would suggest, we do that in connection with our community partner. So optimization, after optimization, I'm sorry, that I should have moved over to evaluation. Once we've optimized the intervention and it's expected to be sufficiently effective, then we move to evaluation to confirm effectiveness of the optimized intervention. And this is actually what we normally think of as a randomized controlled trial in a community setting or in a controlled setting. Okay, so I have really focused on preparation. That's what I'm going to talk with you today. I think in health justice work and in work to address our most pressing challenges of our time, we need to go back to preparation with a lot of our public health interventions. Since many of our behavioral and other public health protection interventions are not accessible or effective among populations experiencing health disparities, I really do believe we must spend time here rigorously investigating if there are additional or alternative targets of intervention that will yield higher rates of intervention success or access to public health protection. And so I have chosen to use the behavior change wheel, a guide to designing interventions, and this framework, something that we call the CONE framework within our research lab. So what this allows us to do, this framework is grounded in evidence-based behavioral intervention theory. Okay, so the public health folks in the United Kingdom really did a pretty thorough review of the literature on health behavior theory and what helps to change behavior, population level behavior. And they created this process for intervention development grounded in that. And so I've chosen to use this because it allows me to look at not just factors within people, but within environments that we need to target in order to help with individual level behavior change and population level behavior change. And by doing so, I use this to identify my set of candidate components to then pilot test and then to identify my optimization criteria. So the CONE model, this really stands for capability, opportunity, motivation, and behavior. And as I said, I use mixed methods and look at things in the physical and psychological internal environment that might need to be targeted. I look at things in the social and physical environment outside that both affect motivation as well as directly impact behavior. And I'm going to walk you through 3 examples of ways I've used this in research. First, on domestic violence survivors' access to advocacy services, then on homeless youth ability to engage and find success with smoking cessation, and then finally to address Ohio's diverse population's ability to access COVID-19 protections. So in 2016, the Ohio Domestic Violence Network received a grant from the Office of Victims of Crime for developing intervention to really assure that their programs were more accessible to survivors coming in with unmet needs regarding mental health and brain injury. And we moved through a health program planning process to create C.A.R.E. So we conducted a needs assessment, designed the program based on those findings. We implemented and evaluated that program. And again, this used community-based participatory processes. This is our Rachel Ramirez. She's our primary community-based partner. And we worked with 5 local programs across the state. So we completed needs assessment focus groups with staff at these programs. And we realized that staff were not recognizing the prevalence or impact of brain injuries on survivors they serve. So this, when administrator said, I've been here 28 years and we're truly have only a handful of TBI clients. And in this other kind of longer quote, what I learned, I was actually the interviewer here, was that I was at a pretty small program, but they had several clients at one time who were having seizures within their program, and it wasn't, they didn't know what it was meant to. So we also completed needs assessment survivor interviews, and most of our survivors who are accessing services in the state are on Medicaid. Some do not have access to health insurance at all. And survivors really are accessing a variety of legal services and other services, safety services, not just shelter. So only 63% of the survivors in our sample were accessing shelter. We asked, how many times in your life have you been hit in the head or made to have your head hit at another object? Over 8 in 10 stated that they had their blunt force head trauma at some point in their life, with almost 50 reporting too many times to remember. And survivors told us how, when we asked how many times in your life have you been choked or strangled, again, over 8 in 10 said this has happened to me. Here with close to 50% reporting a few times and 20% reporting too many times to remember. Blunt force head trauma and oxygen deprivation from choking or strangling, followed by altered consciousness, results in brain injuries, one in traumatic brain injury, the other in anoxic or hypoxic injury. What we learned is that the survivors did not know that they actually had potential brain injuries from these exposures that they had. We collected this data actually off of the outcome interview, but it's important to note that these kinds of assaults are happening concurrently. So the hits to the head and the strangulation are happening concurrently. First time this happened, last time this happened, there is concurrence of these two things. And the reason I'm saying this is because this has sort of made a splash even within brain injury research at Ohio State. Brain injury research has not traditionally looked at domestic violence survivors or interpersonal violence survivors, nor looked at traumatic brain injury and anoxic hypoxic brain injury within the same assault. And so this work is actually leading to additional work at Ohio State around modeling this and bringing domestic violence survivors into this work. So we did publish our needs assessment results and created the C.A.R.E model based on that. C.A.R.E stands for Connect, Acknowledge, Respond, and Evaluate. And really, this came directly from the advocates when we ask them about when survivors do well in their services, tell us about that. Why are they doing well? What are the processes you're using? And this framework was really based on that. We also developed all these advocacy tools to help advocates directly connect with survivors around head injury, around mental health needs, around suicide, around substance use, and to recognize that these are common and pervasive among survivors accessing services, to really destigmatize these issues and to directly communicate with them. And they're free to download on the Ohio Domestic Violence Network website. We handed off C.A.R.E, this framework and these intervention approaches and tools to our advocates, and then we went back out. We let them use them however they did. Advocacy is, oftentimes with our interventions, we're also like very rigorous about the way things are implemented. But advocacy is very all over the place. And what we did is gave them a framework of the way to approach advocacy and tools to use in that practice based on what they told us they needed to work with brain injury and mental health. And we did some direct training around mental health and brain injury for staff at these programs. So that's what they got. We gave it to them, and then we came back out over a year later. We did process evaluation focus groups to understand how advocates were using C.A.R.E. We did survivor outcome interviews and staff outcome evaluations. We did pre-evaluation survivor interviews and evaluation surveys with the staff before we handed C.A.R.E off, and then we did the outcome evaluation as well. And what we discovered is that C.A.R.E works. It improves trauma-informed advocacy practices around a variety of issues, including head trauma, strangulation, mental health, suicide, and substance use. It works because we did the process evaluation, because C.A.R.E increased advocate awareness of brain injury among survivors, and it increased advocate knowledge about brain injury's effects, and advocates started providing social support in a different way to survivors, structural support and functional support. And this really did impact survivors and outcomes. So basically, there was a missing piece, and advocates told us this, and it was very clear to us. Survivors and advocates, including myself, historically, we're putting trauma on the table, we're putting mental health on the table, oftentimes putting substance use on the table, but we were not putting brain injury on the table. And as a possible source of all of the symptoms that survivors were having. This really taught us that brain injury is a clear thing that we have to address in order for survivors to access services, safety services. And we discovered that this card that we developed is a very simple tool that's being used. The advocates are handing off to emergency room staff, they're handing it off to police, they're handing it off to about anyone else they can hand it off to. And it gives very clear instructions about the different ways that brain injury can occur. We don't use brain injury. We talk about when the head is hurt, because that's the language that people were using with us and the advocates were using with us, but gives some information about what to do given the symptoms that people are experiencing. And this was very well liked. Okay, so, I think in terms of the needs assessment was definitely based on Cone B, and we're in the process now of thinking about next steps. I'm not sure if it's optimization yet or identifying additional components of intervention that we need to include in order to optimize. this is the project where it's been most clear about the way that I've applied this process, and this is the career development grant that I've been working on. Many homeless youth are engaged in smoking combustible tobacco. More than half of the homeless youth have tried to quit in the past year, but none really are using evidence-based cessation interventions. They report high levels of nicotine dependence. They're experiencing intersectional structural oppressions and high levels of interpersonal violence. And the awareness of the internal and social context of smoking behavior among them can identify opportunities to intervene with such smokers and thereby enhance population-specific cessation effectiveness. So this is what my career development grant is based on, and I'm in the fourth year of my career development grant. And the first specific aim is to establish that theoretical framework that I was talking about for cessation among homeless youth, incorporating phase-specific capability and opportunity, impacting motivation to engage cessation. And the second aim is really guided by that framework to do really the feasibility testing. And so we implemented, the first part was to do qualitative semi-structured interviews. We interviewed 36 youth, and we recruited on age and motivation to quit smoking. You will notice homeless youth drop-in centers. Actually, I'm partnering with a homeless youth drop-in center to do this research and anticipate that the cessation intervention will be moved out through homeless youth drop-in centers. They serve up to age 24 because at age 18, many youth are exiting the foster system and end up on the streets, and oftentimes are much more developmentally closer to at mid and late adolescence than they are to adult homeless populations. And so the network of drop-in centers for youth oftentimes serves those up to age 24. And so we were looking for themes regarding internal capabilities, the psychological and physical capacities, as well as the external opportunities, the physical and social factors, and that we needed to address in order for homeless youth to be motivated to and engage supported cessation treatment. We did have two coders look at each of the transcripts, and we had an acceptable inter-rater reliability looking at our results. What we discovered is knowledge of the harms of smoking and evidence-based cessation methods is needed. We learned that stress regulation is something that is critically important for this population. I like this quote at the bottom. I think it illustrates it well. It's kind of like a stress reliever for me, like you take in all the bad and exhale, you take in all the good and then exhale all the bad. We also are finding that youth are motivated, that emotion regulation is really critical to the process of smoking and to the ability to quit smoking. That support following cessation lapse is critically important for this population. We asked open-ended questions about their last quit attempt and things that happened that precipitated the lapse that led to the relapse. We have a paper that hopefully is going to get under review in the next week or so that really looks at that process of lapse to relapse. But this is a quote, still was non-suicidal at the time, but I was so depressed. Just they know what to do, just didn't know what to run to. Then the only closest person I knew was that puff of that cigarette. It just makes me sad. Such a deserving group of people to be with. External opportunities. There's a real need for structured social activities with other youth also focused on cessation that's not focused on tobacco and tobacco use. there's a lot of culture around trying to get access to tobacco because these youth are addicted and oftentimes don't have access. And so they are really looking to each other, and a lot of their social interactions revolve around tobacco and tobacco use. But there's also this perception, right, that there's still a lot of smokers in America, and that this is just part of the social fabric. And so there really needs to be social supports in place, as well as drop-in center tobacco-free policies. And this is a touching point that I think is going to be a difficult conversation. Access to basic services is critical. So as I was saying, I don't think I would ever try to help homeless youth quit smoking without embedding this within a service agency that was trying to help with basic services. We went out then and did quantitative validation surveys to try to validate our qualitative findings, and we're really trying to look at what conditions internal to homeless youth and in their social and physical environments are associated with motivation to quit and nicotine dependence. And we also ended up putting brain injury specific research questions on this, because at the time we were doing this qualitative interviews, we were doing all that work with the Ohio Domestic Violence Network, and I was seeing executive dysregulation and all sorts of symptoms of brain injury with the youth I was interviewing, and recognizing their interpersonal violence exposure histories, and that the head and neck are the most likely targeted areas. And so recognizing that interpersonal violence and brain injury could also be impacting these youth and smoking and my ability to help them quit smoking. So we also had some brain injury specific research questions. Eligibility was past 7-day combustible tobacco use, and they had to be using the Homeless Youth Drop-In Center. And as I said, we collected tobacco specific measures, psychosocial factors, as well as brain injury measures. We had to stop recruiting due to COVID, but we did end up collecting interviews from 96 youth. You'll see this is a very diverse sample. We do have about half of the sample is Black. We do have about a third of the sample that is reporting being bisexual or their sexual orientation being other. In terms of age at first tobacco tried, we're looking at 14 years of age, and first regular use being about almost 17 years of age. In terms of the primary research questions, the things that were associated with quit interest in the next 30 days have to do with affect regulation, like we were talking about in the qualitative work. Also denial and disengagement about their coping with their current housing situations, and using smoking as an excuse. So an excuse to get out of dangerous situations. And then when we looked at the Hooked On Nicotine Checklist, which is about the only measure of nicotine dependence that actually works for this population, a population that doesn't have access oftentimes to nicotine first thing in the morning. So looking at measures that actually work for this population, it's very difficult to figure out what works. But factors associated with nicotine dependence, there's more temptation to smoke related to smoking socially or habitually. Participants who use at least 2 types of tobacco products instead of eating while hungry had higher scores. Smokers who endorse smoking to keep their hands busy had higher scores on nicotine dependence. Participants with at least 1 oxygen deprivation scored lower actually on nicotine dependence, making me think that there's something else going on in terms of brain function and the and dependence in the smoking process. And then last, participants who were very confident in their ability to quit smoking in the next 6 months scored lower on nicotine dependence. These brain injury specific questions, I'm going to move through this pretty quickly, but here you can see 61% are reporting any type of oxygen deprivation exposure and 83% blunt force head trauma exposure. Those things that are circled in yellow are intentional. So intentional strangulation, 45% of my sample, intentional head trauma, 67% of the sample, and 40% of my sample has been shaken violently. When I ask who's done this for the oxygen deprivation or for the strangulation specifically, we do see romantic partners, but we also see families of origin above that romantic partner, and peers and others in community settings. For the head being targeted, we see romantic partners and peers being the highest categories here, but also families of origin and others as well. And then I looked at the relationship between altered consciousness, so probable brain injury following these exposures, and the mechanisms known to impact behavior change. And we found race to be associated with brain injury. That's not a mechanism for behavior change, but I just wanted to point out that every single youth in my sample who was multiracial reported probable brain injury. And the probable brain injuries were associated with measures of stress, coping, and anger within my sample. And so I really, 60% of the youth reported blunt force head trauma and oxygen deprivation exposures and altered consciousness. And so I am really in a place of wondering how brain injury is going to impact my ability to help them quit smoking. And so I've been working through trying to identify the components to consider in cessation intervention. And really my next step is to, consider doing a factorial experiment where I'm really, I need to test component interventions first to see if it's feasible in the population, but then move towards some sort of a factorial experiment where I'm actually targeting different things in intervention to see if it's helpful. I'm going to use youth or recruit youth at this point who are interested in quitting smoking in the next 30 days and see if we're focused on some of these interpersonal and environmental targets, if it actually helps the youth. If we deliver these things in addition to what is our evidence-based cessation intervention, if it actually helps to improve cessation outcomes. And so this is more clearly mapping those proposed targets or components of intervention onto the COMB model. And this is thinking through how those cessation intervention components target mechanisms facilitating cessation. But as I said, this is very much still under construction and a work in progress. The last thing I wanted to talk about really quickly is because I work with these populations and because I was down at the Ohio Department of Health just a couple months before COVID-19 really broke on the scene, talking about how it is that we have to target our public health interventions to communities. And I was talking about this process of my work with domestic violence survivors and with homeless youth. I was contacted close to the beginning of the pandemic to assist the Ohio Department of Health in the response to communities and in particular to the health equity working group of communities. And one of the things, the biggest contribution that we made was really leading the Ohio's COVID-19 population needs assessment. And when I say we, I mean me and Taslim Kadamsi and a whole group of people. The Ohio Department of Health at the time was supportive of this launch, but this was really work that was independent. So that Ohio Health Equity Work Group that we were working on really comprised people from the Office of Health Equity, the Commission on Minority Health, our college, the Kerwin Institute, and Deloitte Consulting. And really early on, very early on in the intervention in the pandemic, I really used theory and our knowledge to recognize that there are going to be certain populations who are going to experience the burden of COVID-19 disease and death, and that this was going to be based on populations with pre-existing underlying health conditions, but as well as these behavioral things. So disease spread would happen more quickly among populations who couldn't socially distance due to the context in which they lived or worked. And so really very early on in the pandemic, I think, we predicted populations that we would end up seeing as it came to pass would experience the brunt of disease and death. We modeled where in Ohio those populations would census tracts that contain the populations that would be most vulnerable. And that work was really led by Andrew Miller, who at the time worked for the Kerwin. We led a populations needs assessment to identify the unique needs of diverse populations at risk for disparities in accessing the COVID-19 protections. And based on the data collected from the community needs from members and leaders across the state, we wanted to make specific recommendations about how to equitably design, resource, and implement CDC protections, and what public health interventions needed to take place in order to reduce the disparate impact of COVID-19 across Ohio's communities and support long-term wellness. And again, it's based on this idea that we can't just universally expect our public health protections to be accessible to all. The needs assessment was really qualitative in nature. This was a huge undertaking. The assessment was actually based on the Cone model. So we were looking for both internal as well as external opportunities to support the behavior of the access to CDC protections. And we were looking for barriers that the populations were facing, cultural or situational concerns, ideas that communities had, and stories that communities had, as well as describing community strengths. And we collected data on trusted sources of health information, clinical providers, and community resources. And we collected data for 6 populations within Ohio, and they're listed there. And we had collected data from 363 stakeholders. If you've ever worked with qualitative data, you will understand that that was a huge amount of data to process. We actually had an amazing group of people that worked with us. I'm going to put it up here. This was actually a public service. This was not a paid thing. All these people came together, including us, to analyze data. We had expert panelists. We analyzed data by population. And then we had expert panelists by population that came together to tell us if we got the information correct, really, and the interpretation of the data correct. And then we looked across populations at the CDC protections. And so if a public health department was working on contact tracing and they wanted to understand how best to implement contact tracing so it was accessible, there's a point in the needs assessment that they can look to do that. So just to give you an idea, we did report the findings. These are all downloadable at the College of Public Health website by community. So rural communities, for instance, that's an example, as well as by CDC protection. The thing that I really learned about this, we also have recommendations for each of our key recommendations by population in terms of what can be done at different levels of government and within community to take action on COVID-19 and assuring equitable response. Our central findings, so this is the thing that I really wanted to say. I've never collected this much qualitative data from 6 different populations on the same topic, did separate analysis this way. what ended up happening is our central findings were the same for all 6 populations. There is slight variation in the interpretation of those for each populations, but really these are our central findings. And I think this speaks to the fact that in population health, in public health intervention, these really are the things that we need to target in our interventions to assure they're accessible across all of our public health protection strategies. These are the things that matter. We need to center our COVID-19 response and actually our public health responses in centers of community, and they need to function as the centers of COVID-19 response. So in a lot of ways, the work that I'm doing, with working with community organizations that are trusted by populations already, is the way that we need to be working in public health. We need to be working with organizations that are already utilized and trusted by communities that are experiencing the worst health disparities. And we need to take multi-sectoral community-based approaches that really bring folks together around supporting those centers of community in functioning as the centers of COVID-19 response. And these are the things that we have to focus on, mostly opportunities within the environment, again, not within people, not within populations, but things that we need to change within the environment, including explicitly addressing economic injustices and its widespread health and social impacts by providing resources directly for COVID-19 response, but by reinvesting in communities for long-term health. And things like housing, employment policies, improving transportation services, no matter if that's in our rural populations or among our populations who live with disabilities, or among our Hispanic and Latino populations in the state. We need to improve the quality of education here, COVID-19 education, and we have to address language and communication barriers, again, across all of the populations. This was something that was mentioned. And we do need to address racism and reduce immigration-related fears. And what I can say is, even as we're looking towards vaccine access, it's the immigration-related fears I fear will keep us from a place of not being able to move vaccine and to assure that it's accessible to all populations here in the state. But we are seeing disparate rates of COVID-19 uptake among our ethnic and racial minorities, and these strategies are the strategies that we really need to be using to target vaccine into communities. And so all of that is available on our website, free for download. And we have a working group that is really working on moving interventions into communities and targeting specific work into communities based on these assessment findings. And so that's a picture of them. And thank you.
Thank you so much, Dr. Nemeth. If there are any questions, you can type them into the Q&A feature, or you can use the raise hand feature to request your microphone be unmuted. Dr. Kim-Ozlowski, you could unmute your microphone now.
I think I'm unmuted. Hi, Juliana, this is Jen. Thank you so much for presenting on this really important areas of research. And it seems like you were able to fit in 3 different talks in one, and I'm just blown away by everything that you've shared. So I'm just gonna pick on one thing and ask a question around that. So I'm curious about your work on youth experiencing homelessness, and I'm thinking about the future directions that you outlined in terms of optimizing the cessation interventions. And can you speak a little bit about kind of what defines homelessness in this group or in this work and in maybe that drop-in center. And this is sort of related to thinking about the diversity of your sample. And I'm wondering about kind of the diversity of homelessness experiences and whether that is any point of intervention in that most model. I hope that makes sense.
It does make sense. So I think this is a really, really important question and something that our research team has had to think about. Our eligibility criteria from the qualitative work to the quantitative work changed based on this, actually. We see that we are developing a cessation intervention for any youth that use the drop-in center. So in essence, we are characterizing housing instability among the youth that are using the drop-in center, but to be eligible for the cessation intervention studies, they just have to be using the drop-in center. And yeah, because if you're using the drop-in center, this is the place that we're building the intervention. And so that is any youth that are using the intervention or using the drop-in center will be eligible for the intervention. And it's very nice to see you. And I'm excited to talk about the data tomorrow on food insecurity from the sample.
Great, thank you so much. We're at the time of our seminar. Thank you so much, Dr. Nemeth, for this great talk today. And thank you everyone for joining our seminar for today. Please check in with us through our website and social media as we develop our 2021-2022 seminar series. Thank you, and I hope everyone has a great day.
Thank you.